أنا دكتورة منى حابرة، مستشارة أمراض صدرية أطفال، الخدمات الطبية الملكية، وحالياً ببريطانيا. بعرف الوقت بجوز شوي متأخر بعمان هلا ونهار طويل مع المحاضرات، بس إن شاء الله ما تستفيدوا، ما تحسوا الوضع ممل لإلكم.
دكتورة بس الكاميرا شوي بس عشان تبيني عليها أكثر. أيوة.
أوكي. هلا الموضوع كبير upper and lower respiratory tract disorders اللي هم يعطي، بس احنا رح نحكي mainly عن الانفكشنز اللي بتم بشكل عام الجنرال، رح نتطرق لشويه disorders. فرح يكون التوك مش كتير برود، بس محدد في محلات معينه. هلا لما بنعطى التوبيك هذا اول شيء بخطر على بالي زي الورق اللي بتحط عليها النوتس تاعتك بسرعه، بدي اعمل هيك بدي اعمل هيك، it's a broad topic. بس المهم الجنرال thing مش دائما respiratory tract infection in الصغار او disorders around coughing. في كثير disorders we have to think about, we have to look into. فمش دائما واحد محدد باتجاه واحد. you have to keep a broad mind على ايش ممكن الاشياء اللي تكون يفكر فيها الواحد، ومش دائما هي طلاسم بالنسبه لاي حدا، حتى لو ما بيحب الاطفال او ما بيحب الصدريه اطفال بالذات يعني. وموضوع صدري أطفال مش بس wheezes وأزمة، it's a broad topic. بنقسمهم لموضوعين اللي رح we will approach today. upper airway diseases اللي بتشمل أهم شيء دائما السترايدر، ملخصها رح نحكي عن acute disorders اللي هي بتهم غالبية الناس، والchronic disorders. chronic disorders مهمة كمان للديفرنشال نميزها بأي مرحلة، سواء كنا adult physicians أو pediatricians أو family medicine أو general أو بالطوارئ. lower respiratory tract infections أو disorders رح نحكي عنها infections mainly pneumonias, acute bronchiolitis, wheezing disorders. we'll touch base شوية على البرونكيكتس سواء CF أو non CF disorders اللي هي مش كتير بتهم الجنرال، بس لازم الواحد يكون عارف الديفرنشال تبعها. To know these disorders بالصغار دائما أهم شيء الأيرويز للصغار غير عن الكبار. children are not little adults. what applies to adults is not always true for children. You don't have always to think نفس أمراض الكبار لازم تكون بالصغار. although العلم تغير هلا وصار إنه ممكن أمراض الصغار الكبار تبلش بالصغر. we can avoid lots of these disorders. الأيرويز بالكبار الصغار they always have large head, they have larger tongue. عندهم الhypopharynx is a bit shorter, larynx is higher. most خلينا نحكي narrowest point of the airway in children is the cricoid. It's important دائما إنه نميز إنه it's the cricoid in contrast to adults, which is the narrowest point فيهم, which is the glottis. and the cricoid position بتغير الواحد بس يكبر، عشان هيك بنلاحظ difference بال presentations. croup, which is the most common اللي ممكن يجوا فيه الصغار. the pathophysiology of croup, it involves viral infections most commonly affected by parainfluenza viruses. it affects the upper airway and can affect It's not always the parainfluenza virus and Haemophilus. It can be related to RSV virus, less commonly, and in certain areas, measles that can lead to this.
Why are you even talking in Arabic?
Okay. هلا other characteristic فيها it's the inspiratory stridor. It's inspiratory. There's cough. There's hoarseness. It's a barking cough اللي هي الأحذية أو اللي هي بتصير فيها معها شوية بحة في الصوت بالصغار. It's very common and it can start as upper respiratory tract infection. الكروب لا يشمل فقط upper laryngitis. It also involves variety of other conditions. Laryngotracheitis أو it can go down to the bronchi تعمل laryngotracheobronchitis, bacterial tracheitis and spasmodic croup. هذول they are most important features اللي بنسميهم infectious causes of croup. Who are affected usually? Host factors, it depends on the child. Usually the smaller the children, they can be affected. That there's a host factor. Not all children who get parainfluenza virus infection, not all children who get RSV virus infections get the croup. There is also genetic factors, as it involves as well some exacerbating factors. Could be structural abnormalities, or the patient has reflux, which we refer to as gastroesophageal reflux disease that causes these symptoms. most commonly كلنا بنشوفها وبشوفوها معظم الناس سواء كانوا they treating their family members إخوانهم الأصغر أولاد إخوان خوات. It refers to the inflammation. It's usually limited to the larynx, and usually in older age group it can be seen in older children and adults, but usually it's very mild. The bacterial tracheitis is usually the ulceration and of the trachea. It's a bacterial infection. It's an emergency condition. Usually these children are so toxic and they should not be irritated, should be admitted to hospital, and usually should be treated with IV antibiotics. And most of these children would require intubation. Of course, تبعهم if treated early, within 3 to 7 days, they're okay and they can be extubated successfully. Spasmodic croup في أطفال بيعانوا من recurrent croup. It's usually sudden onset. It's not preceded by upper respiratory tract infection. بيجي فجأة تقول صحي بالليل عنده هاي السترايدر usually خلال ساعات كان منيح ومحلاه وما عنده ولا رشحة ولا مشاكل. It tends to be recurrent in nature. It's more seen in children who have atopic diseases, asthma, allergic rhinitis, and it's usually or reflux disease, and it responds well to simple treatment of the underlying condition أو simply نعملهم humidification أو ترطيب زي ما بنقول للأهل. Important aspects, clinical aspects that should distinguish croup from other acute upper airway obstructions. Fever, usually the absence of fever from the onset of symptoms to the presentation ممكن يكون non-infectious etiology أو spasmodic croup. Non-infectious etiology, you have always to think, and we have to stress that, أنا بنشوف كتير missed cases كان منهم foreign body aspiration that gets stuck into the subglottic area or in between the false vocal cords. Any causatic ingestions اللي بيعملوا لهم حروق شربوا من الهايبكس أو من مواد التنظيف الثانية اللي بتعمل alkali injury. Acute edema, acute angioneuritic edema or anaphylaxis. It's not always croup. It's something you give steroids, nebulizers وتروح عليه. Other important features is hoarseness and barking cough. This is characterized by the presence of hoarse voice and barking cough, and this indicates it's a simple acute laryngitis or laryngotracheobronchitis. The more you see symptoms related to difficulty of swallowing, the more you have to think of the upper airway, other emergency, which is acute epiglottitis, and you have to think of not to irritate the child and keep them calm. Drooling, typically بيجوا الأطفال قاعدين leaning forward, drooling كتير بيسيلوا اللعاب تبعهم. This is more with and epiglottitis. Throat pain, also these patients are more common in children with epiglottitis and peritonsillar retropharyngeal abscess. They feel that there's something in their throat. They have a pain there, and it's mostly in majority of these children. It's less seen in patients with simple acute infectious croup. It's not emergency بالناحية simple croup, but it's emergency significant upper airway obstruction, where you have the risk of rapid progression of these children. There's a detailed Wesley score. It's a bit detailed, بس دائما بنطلع when you assess them زي any infection. ممكن زي any infection نطلع عليهم during the evaluation. نطلع على cyanosis and you score it. Is it 0? Is it 1? Is it 2? Is it 4? Agitation, stridor, presence of stridor at rest أو stridor بس لما when they are coughing. Air entry بالفحص تبعهم or they have signs of distress. Retractions اللي هم signs of distress. أي evaluation لأي patient في primary assessment دائما في أي disease بغض النظر إيش الemergency اللي جاي فيها وإيش عمره. في primary assessment you label your child the patient as urgent or this patient can wait. Secondary assessment you go to look for certain details فيهم. The milder group is the one who have a slower Wesley score, which is less than 2. كل ما كبر كل ما كانوا more severe, and children with moderate group have stridor at rest, and they could have retractions, and these patients you should be careful when you keep them in the emergency. Mainstay of treatment أو cornerstone of treatment اللي هم nebulized epinephrine and steroids فيهم. سريعة شوي أبطئ لكم، ما في مشكلة بنبطئ شوية، بس هاي شوية introduction للأشياء اللي ممكن تلاقوها وتهمكم بغض النظر إنه أنتم امتياز GPs, adult physicians أو later pediatricians أو حتى even surgeons، لأنه ممكن تواجهوا هاي الأشياء with croup post operatively with subglottic stenosis. هاي مهمة كمان تلاقوها. Steroids are the anti-inflammatory mainstay of treatment in these cases، لأنه زي ما حكينا في inflammation في obstruction، فبدنا to target inflammation and obstruction through the steroids. Improvement is usually seen within 4 to 6 hours of administration, so it's not an immediate effect. Immediate effect is to calm the child وإذا بيحتاج humidity. نعطى الستيرويدز IM oral، كل الدراسات لقت ما في فرق بين ينعطى IM أو oral. الoral is less irritating to the child and to the family. It can be given nebulized steroid as well، وفي studies عليهم. مش كل أنواع الستيرويدز بس ممكن ينعطى كمان in nebulized form. nebulized epinephrine اللي موجود بكل الطوارئ بيختلف دراسات التراكيز الموجودة عندنا، معظمها كانت اللي موجودة بعمان أو بالمستشفيات، معظمها غير عن اللي موجودة بالتراكيز اللي موجودة بالمستشفيات الثانية. الابنفرين ما بيغير natural history of the disease، بس usually it decreases الإديمة and it's used in cases where you think you should admit the patient, especially in severe cases. رسمك ابنفرين هو اللي موجود وبنحسب عليه الدوزز. احنا موجود معظمه الابنفرين اللي هو بنعطيه as 0.5 ml per kilo per dose. The most important thing is دائما انه if I give my patient epinephrine you have to remember that you should give steroids، لانه بصير عندنا an entity اسمها rebound obstruction بعد ما ينعطوا الابنفرين، بيروح الeffect of the epinephrine and then after some time this will lead to further deterioration. Oxygen is usually not the treatment of choice unless من ال ABCs كان المريض hypoxic with oxygenation less than 92. ننتبه للأرقام نستعملهم in adults and pediatrics. Usually in children, healthy children with no other comorbid conditions, 92 is the cutoff point, and in some cases you have to be for the 94. It depends on the underlying condition of the patient. الهيميديفايد اير معظم الناس بيقول لك كان مرشح، نعم صحيح، عنده كروب بيجوكوا وجه الصبح عادة بعد الساعة 12، مشيوا بالطريق الهيميديفايد اير، اتعرض للهواء البارد، اموره كويسة، بس وصل كانت الامور احسن، which is the typical case for acute croup اللي ممكن كل الناس تواجهها. Antibiotics usually they have no role, especially for uncomplicated croup, unless we're talking about acute epiglottitis. Once the patient is safe, you can discharge the patient out of hospital. You've observed them ل4 ساعات، ما في stridor at rest, normal gas exchange, and they are not in distress. نرجع نأكد على toxic patients. You have to think of acute toxic infectious conditions, acute epiglottitis, bacterial tracheitis, and retropharyngeal and peritonsillar abscess. Non-toxic نحكي عنهم الكروب, foreign body, hypocalcemia, especially in vitamin D deficiency early on, like exclusively breastfed babies around the age of 3 to 6 months, where it's not the typical age for croup. Chronic cases نحكي عليهم، ممكن تشوفوا other chronic cases فيهم. The chronic or recurrent stridor، تعريف السترايدر lasting more than 2 weeks is defined as a chronic stridor. Stridor is self-limiting، أقل من أسبوع تكون الأمور رايحة. إذا عاد السترايدر more than that, you have to think of other causes. You have to think of structural abnormalities. missed foreign body موجود قاعد هناك، ياما شفناهم موجودين foreign bodies موجود بالsubglottic area، didn't block completely the airway بس هو موجود هنا. comorbid conditions you have to think of and refer them إذا كان عندهم structural anomalies زي ما حكينا subglottic stenosis, especially in patients who had a history of being admitted into hospital أو neonatal unit. The other things اللي مهمة كمان انتبه لها إنه في عنا إشي اسمه البايفيزيك سترايدر. معظمنا متعودين على الانسبيراتوري سترايدر. بايفيزيك سترايدر موجودة على الانسبيريشن والاكسبيريشن أو إذا persistent group زي ما حكينا هدول they should be referred. You have to think of congenital anomalies إذا كانوا صغار أو acquired conditions later on. أحكي لكم عن neonatal conditions I assume اليوم. one of the most common things اللي ممكن تنشاف especially بالgroup early on إذا كان السترايدر in neonatal period early on you have to think of congenital malformations and you have to think of subglottic stenosis. Acquired subglottic stenosis خاصة الأطفال اللي بيعملوا surgeries أو الناس اللي عندهم congenital anomalies أو بيحتاجوا يقعدوا على التيوب فترة طويلة. Usually these patients عندهم history of being admitted into hospital. Usually it's not the duration of the intubation هو مهم. Usually how number of trials the intubation, was it a traumatic intubation, كان في infections, the tube size, was it suitable or not. هدول ال factors that play a role. فممكن subglottic stenosis post intubation to develop even in children who were intubated بس 3 أيام 4 أيام أو ممكن للناس اللي قعدوا أسبوعين 3. هاي بس الجريدنج في subglottic stenosis عشان هيك نحن بنسمع الأصوات. This is a normal subglottic area and this is a stenosed area لواحد كان intubated قديش صغيرة وقديش it will compromise. ودائما نتذكر إنه الراديوس there's an inverse relation between degree of narrowing أو قديش هو في تضيق بالairways وقديش رح يكون.
يعطيك العافية دكتورة، بس في بعض الأسئلة بالكومنتات ممكن دكتورة تشوفيهم؟
لأنه ما كمل عندي لحظة.
أوكي.
ليش مش طالع عندي الباقي لحظة؟ اوكي اوكي اذا بدك احنا بطأنا فاذا ايسيوم المفروض هلا صار حكي اوضح لإلهم. بالنسبة للمواضيع حكينا بالاول اذا ما كان تبع ايش رح نحكي عن upper airway والlower airway وحكينا عن ايش المواضيع رح نتطرق لها. في سؤال احمد طبعا ايش امبولتين ابنفرين على نيو الابنفرين عادة لما بنعطيه نبيلايزر إذا بدك تعطيه نبيلايزر لازم يكون diluted السوليوشن. بيعتمد على التركيز، ما في شيء اسمه تعطيه أمبولتين زي ما حكينا. نرجع للسلايدز بدك تعطيه على التركيز. إذا الريسمك ابنفرين اللي هو مش موجود عادة بمعظم مستشفيات الأردن أو إذا الابنفرين اللي موجود. هلا laryngomalacia is usually the most common cause of chronic stridor in neonates. فاحنا ما عم نحكي عن السترايدر بالنيوناتال period لانه اخذت neonatal disorders رئيسيهم كان في محاضرات الصبح عنها، بس احنا عم نحكي عن croup and croup is one of the stridors اللي ممكن تيجي. هلا اللي بتيجي ايش الاشياء المواضيع اللي بتيجي امتحانات الامتياز anything ممكن يجي. فهون فكرة من موضوع المحاضرات اللي أنا فهمته مش إنه إيش بده يجي أو أسئلة، اللي بعرفه إنه بدك تكون عارف عن هاي المواضيع which is the most common topics اللي مهم تعرفها، مش detailed subspecialized things that you should know. فما بقدر أركز على الأشياء اللي بتيجي من أسئلة بامتحانات الامتياز. وبتابع معكم أول بأول على الكومنتس. أوكي. فزي ما حكينا الفيرال جروب او السترايدر infectious اللي حكينا عنها it's a self-limiting disease والrecurrent you have to make sure you're giving that. فملخص للجروب او acute infectious upper airway diseases you have to be careful. This is an acute thing. Chronic is more than 2 weeks. Acute you have to rule out infectious causes. Infectious causes تشمل toxic patient, ill-looking patient, epiglottitis, retropharyngeal abscess, subglottic peritonsillar abscess, bacterial tracheitis. Non-toxic patient you have to think acute laryngitis, laryngotracheobronchitis اللي هم كلهم التيرمز اللي بيدخلوا تحت group. They are usually self-limiting. Other causes of non-infectious acute group you have to bear in mind not to miss it لأنه we're talking about practicals إيش شفنا من الناس what they are missing الهايبوكالسيميا مهمة as they cause angioneuritic edema and and anaphylaxis and foreign bodies especially بالtoddler age group اللي كل شيء بدخل بتومهم. التريتمنت زي ما حكينا it varies بس حسب السيفيريتي. Epinephrine is not given to the mild cases زي ما بصير. Steroids usually preferred route اللي هو oral route بالsteroids هناك. The other infection causes which is the pneumonia. Pneumonia is inflammation of the lung parenchymal disease, and usually the definition تبعها is just inflammation. إيش community acquired pneumonia لأنه في عنا pneumonias related ل hospital acquired for patients who are admitted into hospital. With community acquired pneumonia. Community acquired pneumonias usually a pneumonia that happens in a previously healthy child that has acquired this outside the hospital settings. Most of the children are usually younger age groups, less than 2 years. 80% of them are less than 2 years of age, and usually its mortality has differed among countries more. With severe pneumonia ممكن توصل 10%, and this is more in the developing and poor countries. ظلت community acquired pneumonia as the second most common cause of childhood mortality, and the neonatal period diseases or prematurity is the most common cause of mortality in children. Seasonal variation دائما نشوف pneumonia it has different seasonal variations related to winter, and usually there are it accounts for most of the hospital admissions in winter. Winter season بيختلف حسب different countries. It can extend from October down to January and February. Winter predominance is also noted لأنه في عنا viral infections. When you look at that, it's not just radiological. The pneumonia زي ما حكينا it's inflammation, but it's not always radiological. Usually what you have to look for clinical signs and then you go for radiology. Radiology الإكس-rays أي إكس-ray بده يقرأها الواحد has to look into the ABCD نفس المبدأ تبع resuscitation. ABCD involves looking into the airways, the trachea, lungs, lung parenchyma if they are normal. B into the bones as well. You have to look into the bones and the soft tissues around. Cardiac with the C, and the diaphragm. Any abnormality ميز which side, right and left. We don't have to tell lobes نحكي عن zones فيها. But this is one of the things that we say it's collapse, consolidation of that part of the lung. This is how we approach in general the lungs. Most common cause of community acquired pneumonia in children is still viruses. It varies the cause of the virus حسب the age group. Still, influenza is the most common, followed by human metapneumovirus and RSV. The most common bacterial cause of community acquired pneumonia is still the strep pneumonia. فرقت الstrep pneumonia now with different things is that vaccination بالأردن vaccination against pneumococcal is not part of the national program. هاي مهمة بس المهم إنه still it's the wild word most common cause of bacterial infection. Less frequent cause ممكن يكون group A. The community-acquired pneumonia and it causes infection with older age groups عادة. Okay? There's no single sign or symptom حتى نحكي this is pneumonia. Usually they have upper respiratory tract infection followed by fever, cough. أهم شيء نفتش على lower signs tachypnea اللي هي increase in respiratory rate, breathlessness or difficulty in breathing أو increased work of breathing. وممكن نلاقي other symptoms موجودة such as wheeze or chest pain. Some of the children ممكن to complain of abdominal pain فلازم دائما ننتبه إنه abdominal pain is not always surgical abdomen, it's not always related to abdominal conditions. It's referred pain. They can have especially with basal pneumonias بتيجي بالbases of the lung ممكن تعمل abdominal pain especially كمان إذا كانت complicated. Not all children have radiological changes early on. وممكن يجي يكون عنده pneumonia بس early on تكون X-ray with normal findings. But most of them they would have the typical presentations of cough, fever, and hypoxia. The most important sign واللي هي بيستعملوها بتعريف النيمونيا بال WHO especially للareas when the X-ray is not available دائما. فدائما relatively specific is the tachypnea, which is the increased respiratory rate. If its sensitivity تاعتها would increase إذا كانت associated with hypoxia and could include other signs that respiratory distress المهمين اللي هم الgrunt, nasal flaring, chest retractions, subcostal recessions or indromies. On examination, the typical findings ممكن نلاقي decreased air entry, ممكن نلاقي crackles or capitations اللي هم نفس التعريف بالauscultation. ممكن يكون في wheeze especially بالcases في الviruses أو بالatypical bacteria. وممكن نلاقي signs related to the complications of this pneumonia as in dullness to percussion. زي ما حكينا radiology when to look for and what to look for. It's not the most important investigation in diagnosis of pneumonia. It's one of the things that would tell you for the complications, and it's not a routine investigation زي ما الكل بيعمل في الطوارئ. أهم شيء pulse oximeter. This tells you the indication to admit these patients. So the indications for admission of these patients if they have hypoxemia and hypoxemia where the oxygen saturation in room air is less than 92. Other indications for investigations الناس بتاخد white blood cell count أو CBC. Usually it doesn't differentiate between viral and bacterial, but the higher the white blood cell count, the more it indicates it's bacterial. And the higher the white blood cell count ممكن يحكي إنه والله في other complications related to this pneumonia. Acute phase reactants are important for follow-up rather than the diagnosis. Other things that we look for the electrolytes. Usually electrolytes مثل الكدني function we look for them to tell the degree of dehydration عشان مهمة في التريتمنت والantibiotic choice to adjust the doses. Other things ممكن نلاقي عندهم hyponatremia وهاي مهمة الهايبوناتريميا no matter إيش تخصصك. الهايبوناتريميا في الادلتس أو بالpediatrics in pneumonia you have to think of syndrome of inappropriate ADH. This is why we do these investigations for these patients. عادة we don't look for microbiological investigation in sputum. We usually don't consider it في milder cases. We consider it في الناس اللي عندهم severe أو complicated. What we look for blood culture. Sometimes we do the PCR for nasal swabs أو NPAs. المهم antibodies serology sometimes for atypical cases. إذا كانت complicated بناخد cultures related للفلويدز وهلا بنحكي عن complications. زي ما حكينا مهمة تحدد the severity of the disease. كل ما كان distressed, tachypnic, requiring oxygen, في degree of cyanosis, في dehydration, these are signs مهمة to indicate that we should admit these patients. Patients with persistent hypoxemia, أكسجين لسه نازل مش عم بيتحسن ضلت الحرارة موجودة. Even if he was treated for 48 hours with oral antibiotics, you have to think of pneumonia with effusion. هاي من الأشياء المهمة. حكينا عن general management. ليش بنعمل هاي investigations? Usually patients, most of the children that have community acquired pneumonia are treated in the community as well. They can receive oral antibiotics. Usually, most of the times, unless they are penicillin resistant, you can use coamoxiclav اللي هو الأوجمنتين وجماعته أو ممكن يستعمل macrolides in cases of sensitivity أو add-on treatment حسب العمر. Chest physiotherapy عادة من الأشياء اللي الناس تغري بالpneumonias they treat pneumonias with. It's not indicated, it's not beneficial, and usually it has no role for these patients. Symptomatic treatment دائما fluids أهم شيء. Oxygen, pay attention to syndrome of inappropriate ADH and the appropriate antibiotics. زي ما حكينا مش دائما IV antibiotics unless it is complicated. This is still the antibiotics اللي حكينا عنها اللي هم الأموكسيسيلين أو الكوأموكسيكلاف اللي هم من عائلة البنسلينز. They are the first choice to be used. Macrolides can be add-on or they can be used in case there is any hypersensitivities to the penicillins. Complications. We diagnose this patient. عمره إجا بالنيمونيا. He's diagnosed with pneumonia. سواء كانت clinical أو radiological. أخذ treatment. Still على اليوم الثالث الرابع still he's having fever. Fever is persistent. It's not responding much. And he's having other features related to being unwell. The X-ray would relieve complications. We have to think of complications. Complications of pneumonia could be pleural effusion, which is the accumulation of fluid in the pleural space. And this can be clear fluid or empyema. Empyema is the pus accumulating in the pleural space. And these are usually called paranemetic effusions because they are secondary to pneumonias. ممكن النيمونيا نفسها يصير فيها necrotizing. The bacteria that is present there تعمل liquefaction we call it. بتصير في necrosis, بتصير في infection, بتصير البارينكايما more and more disease. Most commonly this occurs more with Staph aureus and it causes more with group A strep, but still it can happen with any type of bacterial pneumonia, even viruses. These patients, they usually need prolonged courses of antibiotics. For effusions, paranemetic effusions or empyema, مش دائما chest drain is the solution. Simple ones with no respiratory distress or mediastinal shift, you don't have to put chest tubes. Lung abscess is a complication of pneumonia, and usually it's a thick-walled one. It can occur secondary to bacterial infections, Staph aureus, and it can usually microorganisms الموجودين بيكونوا mixture of microorganisms, anaerobes plus aerobes. وتلاقي gram positives فيهم وتلاقي gram negatives وتلاقي anaerobes. عشان هيك the treatment is usually very prolonged treatment course of antibiotics. Surgical treatment is an option فيهم, but nowadays صاروا الناس يستعملوا فيهم very thin drainage زي كيف الchest tubes بنحطوا للpleural space بنحطوا للlung abscesses. This is one of the X-rays. نفس الإشي دائما نطلع على الإكس-راي. وين الباثولوجي موجودة نطلع على الhealthy side. وين الباثولوجي موجودة we have to look for. This is abnormal. This is abnormality is not just related to infection, في fluids, and this is what we call the paranemetic effusion, and this is the meniscal sign there present on that side. يصير في obliteration of the costophrenic angles. One of the earliest signs. كل ما زاد الفلويد ممكن يعمل mediastinal shift فيهم. This is one of the إذا هون واضحة الcysts اللي ممكن تصير بالnecrotizing pneumonia. إذن الإكس-rays بالpneumonias usually to detect response to treatment and to detect complications. وعادة الfollow up للcomplicated pneumonia بالإكس-rays you should have a normal X-ray towards the end of treatment. يعني مش بس إنه في pneumonias بتركهم راح يتحسن clinically ما في مشكلة. هلا الother thing اللي بدنا ننتبه لهم إنه في أخذتوا موضوع الimmune deficiency أكيد اليوم الصبح. في شيء اسمه recurrent pneumonias اللي هم pneumonias that occur more than 2 times a year بالصغار بنسميهم, or usually if it's a significant pneumonia. Unresolving pneumonia that fails to resolve radiologically in between. Most popular causes of children with recurrent pneumonia لازم to refer these children if they have recurrent pneumonias for evaluation. Either these patients عندهم immune deficiency أو في عندهم structural malformation باللنج نفسها, في abnormality بتركيبة اللنج أو الvessels حوالين اللنجز, أو في underlying problems related to cystic fibrosis, التليف الكيسي, primary ciliary dyskinesias, patients with recurrent aspirations سواء كان patients especially CP patients أو patients with any swallowing dysfunction related للneurology أو related ل unsafe swallow فيهم. وزي ما حكينا foreign bodies are quite important especially in toddler age group. These patients with toddler age group ممكن يبلعوا أي شيء بطريقهم ينزل وما حدا ينتبه له, تشردق 5 دقايق ومشيت أموره, بس later on يعمل له recurrent pneumonia أو persistent radiological pneumonia. طبعا ما بدنا ننسى atypical infections اللي هم مش موضوع certain atypical diseases اللي بيكونوا بالimmune deficient patients أو الناس اللي عندهم certain endemic areas بالTB. You have to think of these. دائما look for underlying cause إذا كانت severe, persistent, unusual, multifocal or recurrent. هدول من الأشياء المهمين when you evaluate any patient for recurrency. استراحة كيف كنا بشهر 11 2020 نقدر نعمل برونكوسكوبي من غير ما نلبس ماسك وتمشي الأمور، وبشهر 3 2021 كيف الأمور تغيرت بسرعة والطب تغير بسرعة، فلازم الواحد يضل دائما أهم شيء up to date بالعلم اللي بيمشي فيه، لأنه كل شيء بتغير بسرعة. ننتقل لموضوع infection تانية. Indication for admission to hospital for pneumonia in children. نفس ال indications of adults، بس الفرق ال extremes of age مهمة. extremes of age يعني الناس الصغار كتير أو الكبار كتير بالعمر you have to admit them to hospital for treatment. Those with comorbid conditions زي ما حكينا عندهم underlying other condition، يعني واحد with immune deficiency، واحد بياخد chemotherapy، واحد عنده cystic fibrosis, sciatic congenital heart. These patients should be treated in hospital for their pneumonias. Patients with evidence of dehydration, patients with evidence of renal impairment. طبعا all signs of distress. Patient is distressed, tachypnic, hypoxic, requiring oxygen. These should be dealt with in hospital settings مش بالبيت. Other indications sometimes socially ساكنين بعيد and you can't provide adequate follow-up for these children. Sometimes this is an indication for admission for these children. Bilateral pneumonias is indication for admission of these children, or sometimes simply you're not sure of what you're dealing with. You can admit these children even if they look clinically well. Okay. في أسئلة تانية عن pneumonia. So pneumonia's most common cause is viral pneumonia. Most common bacterial cause is streptococcal pneumonia. Types بتختلف حسب ال countries. Vaccination has not covered all the serotypes of pneumococcus. Because this is بالأردن برضو this is not part of the national program for vaccinations. Pneumonias ننتبه ال comorbid conditions. Community acquired pneumonias الapproach تبعها simply the first line of treatment is monotherapy، لأنه لما بصيروا complicated pneumonias أو complicated pneumonias أو patients with comorbid conditions you have to think of double antibiotics أو triple. نستعمل antibiotics أكثر من واحد. You don't use just monotherapy فيهم. Okay. ما في هلا بننزل من الايرويز. خلصنا من الابر ايروي، خلصنا من الابيجلوتس، خلصنا من شوي من التراكيال انفكشنز سواء اللي very severe toxic acute bacterial tracheitis او laryngotracheobronchitis. خلصنا شوي من اللنج بارينكايما، ننزل للبرونكيلايتس. ما في شيء بالصغار اسمه acute bronchitis زي الكبار كل الناس متعودة على acute bronchitis والتريتمنت تبعهم. الصغار this is not present. في عنا شيء اسمه chronic bacterial bronchitis. Yes, بس هذا مش for your level. بس it's not شيء common للصغار the whole population. The acute bronchiolitis is quite common. Bronchiolitis is usually an acute viral infection, lower respiratory tract. Mostly if they're very young. It occurs in infants under the age of 2 years. It tends to occur مرة واحدة، بس ممكن تصيبهم أكثر مرة. And it's peaking between 3 and 6 months. دائما diagnosis تبعها is a clinical diagnosis, and it depends on clinical presentations or symptoms. Majority of children is self-limiting. ما بدها ولا treatment is always supportive. Well hydrate, keep them hydrated. كل trials of any treatment failed unless كان المريض عنده other comorbid conditions. في risk factors for acute bronchiolitis، وهاي مهمة risk factors لأنه في environmental factors related to smoking، وأهم شيء دائما smoking, passive smoking والmaternal history of smoking. حتى they link this smoking the risk of acute bronchiolitis in the first year of life. والwheezy bronchiolitis in the first year of life is more related to antenatal قبل الولادة exposure، لأنه بيحكوا smoking can decrease the lung size in children of smoking mothers or mothers exposed to smoking even as passive smokers. Presence of older siblings أو nursery attendants. نلاحظ دائما bronchiolitis أكثر الأطفال اللي بيروحوا على الحضانات. ودائما في something that occurs to children that go to nursery is that you can sometimes have 10 to 12 infections per year and you can still consider them as normal without the need of having further evaluation. Overcrowding is important as a risk factors. Risk factors for severe disease, premature babies و low birth babies, those who were admitted to the neonatal unit بيكون عندهم أكثر. وزي ما حكينا دائما comorbid conditions related to chronic lung disease of prematurity أو chronic lung disease related to comorbid conditions the PCD, the cystic fibrosis, neurological disease, congenital heart. These comorbid conditions make any child more liable to severe diseases سواء كانت upper or lower airway infections. You don't have to investigate for acute bronchiolitis. بيجي مريض قعد له يومين ثلاثة في رشحة في أحة نزلت lower airways. في difference بين الأمريكان وراح تلاقوها شوي ملخبطة بالكتب بين الأمريكان والإنجليش. Those in UK they don't consider wheeze as part of the definition of bronchiolitis. يعتبروا أي acute respiratory distress in children infants less than 1 year of age as acute bronchiolitis. If it was related, is associated with wheeze or recurrent wheeze بسموهم wheezy bronchitis اللي هي بتصير recurrent to evaluate later on different diseases. بالأمريكان definition لازم يكون في wheeze معهم بيعتبروها it's acute wheezy process. دائما chest x-ray والبلد test والبلد gases are not part of the routine. أهم إشي clinical picture دائما أي مريض بيجي primary assessment is he distressed تكبنك clinical condition of that patient بعدين بتحدد the quick look of the patient بعدين بتحدد line of management. Pulse oximetry is very important بأي decision سواء بالطوارئ أو بالأقسام. Pulse oximetry tells you the oxygenation status and it عادة تغني عن doing ABGs بهدول الأطفال اللي موجودين بالطوارئ أو مش بالICU setting موجودين بالطوارئ أو موجودين بالأقسام. If there's evidence of deterioration or worsening of their respiratory distress or there's oxygen requirement or any focal chest signs بالexamination you can do a chest x-ray. مع العلم إنه 30% of these children they have radiological pneumonia بس ما في pneumonia. You can find the radiological findings on chest x-ray but it's not necessary that it indicates pneumonia. So أكيد لهلأ في واحد مبتسم لساته بيناتكم مع المواضيع الطويلة والعلم الكتير بس تمرق الأمور. So this is the acute bronchiolitis. The treatment is always supportive. So you have always to make sure it is supportive. زي ما حكينا differentiation between bronchitis and bronchiolitis. Children ما عندهم an entity called acute bronchitis زي الكبار زي اللي بنسمعهم بالصغار. اللي بنشوفهم بالكبار ما في entity اسمها acute bronchitis. في عنا bronchiolitis which is inflammation of the bronchioli and this is usually viral. في entity اسمها chronic bacterial bronchitis which is a chronic productive cough and it tends to occur in certain age group usually following infections and has a different protocol for treatment which is it has a different approach بالtreatment والmanagement فيهم. فبالصغار ما في bronchitis bronchitis لأنه ما في term اسمه acute bronchitis أو entities تعمل disease acute bronchitis فيهم. Okay. هلا بننط على موضوع ننزل تحت كمان اللي هو مهم اللي هو الكافينج. والكافينج بيشمل كثير اشياء بالصغار. مهم نميز انه الكافينج انه كان بي acute وكان بي chronic. الاكيوت is usually symptomatic treatment self resolving ما حدا بيسألكم عنه. الكرونيك هو المهمة فيها لأنه الكرونيك فيها الانتيتيز اللي بتهمنا. Nature of the cough it's always the classical teaching whatever exam you go for. chronic productive or even productive cough يعني wet cough يعني الأحة اللي فيها بلغم especially إذا كانت chronic is always pathological and it's not asthma in children. يعني واحد بيجي wet cough أو productive cough you don't label them as having asthma. فتنتبهوا even إذا أنتم الانترست تبعكم مش pediatrics بيكون في قرايب من أطفال بيقربوا لكم أو في أولاد إخوان خوات قرايب you have to تنتبهوا فيها. diurnal variation هلا بدنا نحكي على هدول السيمبتومز اللي هي بتدلنا للأزمة. الأزمة تريتمنت الأزمة definitions والتريتمنت كلها بتشبه الديفينيشنز للكبار although بنغير تقسيمة الأعمار فيهم. يعني الناس اللي less than 1 year you don't diagnose asthma in those less than 2 years. ممكن تبلش تاخد preschoolers في entities تكون related بين 3 ل 6 سنين، وفي فوق 6 سنين وفوق 12 سنة بتبلش similar protocols للadult protocols. diurnal variation يعني في فرق بين روح أكثر بالصبح خلال النهار أو بالليل، لأنه بتفرق على differential diagnosis. زي ما حكينا ال cough that occurs during the night is more related to bronchoconstrictions related للأزمة أكثر. early morning cough بدنا ننتبه خاصة ال chronic cough لل post nasal drip cough واللي هي entity بالكبار أكثر من الصغار بس still can happen. أو ال cough related ل suppurative cough اللي هي بنلاقيها بالbronchiectasis أو اللي هم primary ciliary dyskinesia أو cystic fibrosis patients اللي عندهم suppurative lung disease. Other associated symptoms, exacerbating factors, symptoms of family history هلا نجي عليهم. اللي بتهمنا دائما الأزمة أهم من ما نحكي عن ال PCD وال others. الأزمة cough in asthma is mostly dry. You don't have unless كان في super added infection تصير productive cough. So productive cough, wet cough, you have to have different referral لهم. زي ما حكينا more at night. It responds to bronchodilators. تسأل هذا المريض تحسنوا بعد التبخيرة واللي هم البرونكودايليترز، ومعظم التبخيرة متعارف عليها اللي هي السالبيوتامول أو nebulizers. Is it associated with wheeze? Usually dry cough alone is not associated with asthma. You have to be careful لأنه wheeze bronchoconstriction هو الهولمارك of asthma. والأزمة في زي ما حكينا diurnal variation بيكونوا أسوأ بالليل بس الصبح أحسن، وفي symptom free periods يعني في variability أو seasonal variability in these patients. In the examination of asthma إذا إجا in between attacks they have normal examination. بس إذا لقينا بالexaminations that indicate chronic serious lower respiratory tract disease you have to think of other diagnoses. Failing to thrive زي ما بكل المحاضرات اللي اتاخذت دائما in children بعد الhistory the physical examination the growth parameters are very important. Growth parameters if the patient is failing to thrive you're looking for a serious condition سواء كانت respiratory أو إذا كانت GI أو malabsorption أو metabolic abnormality endocrine abnormalities لازم ننتبه للgrowth parameters. Finger clubbing, this is very important. It's one of the signs of chronic suppurative lung disease. من الديفرنشال الفينجر clubbing واللي هي common بالامتحانات نسألوا فيها. There is chronic suppurative lung diseases. Asthma is not a cause of finger clubbing. الإشي الثاني اللي ممكن causes of clubbing cyanotic congenital heart, inflammatory bowel disease, chronic liver disease, and very rarely but could be in long-standing untreated celiac disease as a cause of finger clubbing. Chest deformity is very important with examination لأنه chest deformity it can be indicate upper respiratory tract obstruction or it can indicate recurrent lower airway diseases and infections that are not treated. Other اللي بنسموها بالأيام هاي atopic march you have to look for اللي بيبلش عندهم هدول صغار إكزيما وهم صغار، بعدين الإكزيما اللي بتكون مش الكريديال كاب أو السمنة على الراس this is not part of the eczema. الإكزيما اللي بتبلش على الشيكس بعدين بتبلش على الأرمز وعلى legs. This is one of the atopic march early on تكون إكزيما اللي بصير عندهم allergic rhinitis بعدين يصير عندهم respiratory أو bronchial asthma. ممكن تكون associated higher incidence of certain allergies للfood. This is it can happen but it doesn't mean إذا واحد عنده food allergy they should have more they have for ear infections أو دائما الدنيا بتسيل يعني عندهم مع chronic cough مع تكون wet cough you have to think of immune deficiency in these children. Presence of lymph nodes, heart murmur, not all cough or not all wheezes as always related to lung. ممكن تكون related to heart failure and cardiac conditions. Organomegaly, كل ما لقينا other involvement of other systems, we have to think of other diseases rather than simple asthma. إذا إجا المريض with wheezy chest, we don't have to do lots of investigations unless كان في عنا زي ما حكينا pointers أو نسميهم red flag pointers في أي disease في other underlying condition. CBC بيفيدنا in case إذا كان في eosinophilia. It goes more with asthma, but not necessarily. There are certain immune deficiency conditions that can lead to eosinophilia. Neutropenia, lymphopenia, you have to think of immune deficiency فيهم, especially early on. Okay. Chest X-ray, it tells you أكتر X-ray we usually do it not to look for to diagnose asthma. ما بنحكي إنه والله على X-ray تشخص asthma. X-ray to exclude other conditions, congenital malformations, persistent shadows, heart conditions. You can look for cardiomegaly بالX-rays. Sweat chloride test. Sweat chloride هو فحص التعرق اللي الناس بتفحص فيه عشان to look for cystic fibrosis, especially when there is no neonatal screening for cystic fibrosis or certain conditions. You have to do this sweat chloride test لأنه في بيصير delay بالdiagnosis. Immune screen حكينا عنهم. pH monitoring للناس اللي احنا بنحكي من relations في reflux disease اللي هو الارتداد المريئي. الارتداد المريئي is common in children. It's not always pathological, بس إذا صارت pathological بنصير نسميها gastroesophageal reflux disease. جماعة الجاستروانترولوجيست حتى البيدياتريكس مش بس الادلتس ما بيآمنوا كثير بعلاقة الريفلكس مع الكرونيك respiratory conditions, but it is there and you can treat them and improve the patients. Pulmonary function, usually patients with, you have to do pulmonary function. It tells you بالpulmonary function إذا في reversibility زي ما حكينا بالأزمة. الأزمة should have a reversible bronchoconstrictive disease with diurnal variation or seasonal variation فيهم. Bronchoscopy, it's not always first line of investigation. Usually you keep it للadvanced cases إذا كان في persistent radiological changes مش متأكد من diagnosis. It has certain indications. إذا bronchial asthma we suspected with chronic cough, it should be dry. Recurrent pneumonias without bacteriological proof, especially early on, if you have to think of these patients tend to have recurrent wheezes and recurrent infections and equivocal response to salbutamol nebulizers or Ventolin nebulizers. These patients would have, they give you the answer, والله تبخيره بتحسن أموره بيروح ممتاز, and then this is a reversible airway disease. I don't have to do further testing فيهم. إذا حكينا عن الأزمة definition, ننتبه للأذر ميميكرز ونضل نركز على variability في هاي diseases. symptom free periods زي ما حكينا, seasonal variation, diurnal variations, environmental factors. attacks of acute attacks of asthma, guidelines دائما معظمهم بدنا ننتبه فيهم how to treat them. دائما نرجع نأكد على primary evaluation of these children, primary assessment of severity of any disease, بعدين نيجي للsecondary assessment. بالinterventional medications نستعملها الnebulizers, the systemic steroids, magnesium sulfate, and even adrenaline. Systemic steroids mild attacks أو mild to moderate attacks ما في difference بين نستعمل systemic steroids as IV, oral, IM, as long as the patient is tolerating oral steroids. نقدر نعطي oral steroids for weaning doses for 5 days. Okay, كل ما كانت severe attacks, I need to have more interventions in terms of giving them magnesium sulfate. Magnesium sulfate is usually given IV. بلشت دراسات عنه بينعطى المغنيسيوم sulfate as nebulizer كمان. And this is and the magnesium sulfate nowadays can be recommendations القديمة, it's only given for ICU cases admissions. ممكن ينعطى هلا onwards وبالطوارئ to prevent ICU admissions of these patients in children. Adrenaline can be given as nebulized and can be given epinephrine as sub-Q. الفنتولين أو اللي هو السالبيتامول can be given nebulized. عادة ممكن ينعطى السالبيتامول بينعطى نبيلايزر، ممكن ينعطى كل ربع ساعة بالطوارئ، بنسميهم back to back nebulizers, or it can be hourly, but you should review your patient for side effects. Most important side effects منهم hypokalemia، ممكن يدخل البيشنتس في arrest and to die of this thing, or tachycardia, and usually you have to monitor them and to stop إذا صار عند المريض more than heart rate more than 200. Anticholinergic can be an alternative to salbutamol nebulizer إذا كان في complications من الفنتولين، أو في ناس يصير عندهم bronchospasm instead of bronchodilatation من السالبيتامول، أو في ناس ممكن يكون عندهم الريسبونس أحسن، نستعملهم usually as acute settings. Again نطلع على indications for admissions for these patients. Severe attack. Is it oxygen saturation is not maintained above 92%? They are dehydrated, apneic, inability to talk. Previous history of ICU admission is an indication to admit these patients. معناته they can rapidly progress. Social factors and neglect مهمين. Respiratory distress with feeding activities and talking. These are all indications, even if they are maintaining them. للطوارئ بروحه if he's able to complete sentences, not using his accessory muscles, is able to maintain his oxygen without any supplement أكثر من 92%, and they can usually given a plan, نسميها action plan for these patients. They should have an action plan to what to do in case they get more severe symptoms, whom to contact, وإيش يساووا بالweaning plan of steroids والweaning plan of their salbutamol or ventolin inhalers اللي نعطوا إلها. These are just combinations. Inhalers اللي بالصغار بنستعملهم زي الكبار, and this is they can be used. The other thing بس الرول of الانتيلوكين giants أو اللي هم صاروا singular, they are usually less used بالacute attack. They can be used بالmaintenance. عادة effects تاعتهم as مش كتير الكل they like to use them as their use for asthma, but they can be used لأنهم سهل يتقبلهم الطفل تحت عمر السنة. بس they are certain conservations عليهم لهلا كاستعمال للmaintenance treatment للأزمة. ودائما بالfollow up growth parameters, complications related to steroids, complications can be related to cataract, hypertension, blood sugar abnormalities, كل هاي بالsystemic steroids. Frequent exposure to systemic steroids ممكن تعمل هاي complications, or even nebulized steroids can lead to cataract and eye abnormalities. والأزمة control اللي هم questionnaires اللي later on لما بتتخصصوا بتشوفوهم. Quick thing عن cystic fibrosis. Cystic fibrosis is an inherited disease, يعني it's an autosomal recessive disease. You have to dig into family history. It's usually a chronic disease. Systems involved, it's a multi-system disease. It can involve respiratory tract most importantly, and most of these patients they die of the respiratory involvement. Gastroenterology, liver, reproductive system, and the sweating. أي مريض بيجي with predominantly respiratory tract infections, recurrent infections, evidence of chronic disease فيهم, you have to think of cystic fibrosis. Other rare manifestations مهمة نشوفها فيهم هدول الأطفال. Early on you have to think of them. They can present with neonatal intestinal obstruction as surgical disease, so you have to think of بالmeconium ileus, you have to think of cystic fibrosis early on. Other things you have to think about the dehydration of these patients. خاصة ببلادنا they present with الشوب with recurrent hypotonic, hypochloremic, metabolic alkalosis. فهي مهمة بالديفرنشال في هدول المرضى. Neonatal jaundice, you have also to think of one of the differential is cystic fibrosis, because it's one of the things that you can treat nowadays, cystic fibrosis. Okay. Diagnosis ما في details كتير يدخل عليهم. They need you can do neonatal screening. Neonatal screening you can pick these children. Sweat chloride مهمة في diagnosis. We have to have readings more than 60 فيهم. Genetic mutations مش دائما متوفرة بكل محل, وإلنا أكثر من 2000 gene mutations في هدول المرضى. But it's not always the genetic. الجينيتيك مهمة إذا نعرفت للتريتمنت, لأنه nowadays صار في treatment for cystic fibrosis. والتريتمنت حسب الcomplications تاع تاعت هدول. mainstay of treatment فيهم هدول المرضى هم is related لل treatment of infections and antibiotics. Okay. It's a quick rough idea عن ال respiratory tract infections. إيش سؤال سويت كان هنا؟ أوكي حكينا عن with recurrent pneumonia حكينا different في سؤال any patient with recurrent pneumonia we think about cystic fibrosis. طبعا one of the things that you have to think about زي ما حكينا recurrent pneumonia أو persistent pneumonia أو radiologically unresolving pneumonia you have to think of chronic بنسميهم suppurative lung diseases اللي منهم cystic fibrosis primary severe dyskinesia أو congenital malformations. Immune compromised patients most common organism cause respiratory disorders حسب وين ال community acquired ال immune compromised patients ما بنعالجهم زي ما ضل ال community acquired with monotherapy you have to have 2 forms of antibiotics because ممكن يكون عندهم gram negatives ممكن يكون fungal diseases so you have to be careful with immune compromised patients you have to think of fungal diseases as well أو allergic resistant microorganisms. Cystic fibrosis the most common cause فيهم pseudomonas and treatment lines of treatment فيهم تختلف. صار في هالأيام كمان مو بس IV antibiotic treatment لهم nebulized antibiotics which is beyond the scope. حكينا عن الأزمة which patients need treatment حكينا عنها. ال patients that need treatment with acute asthma attacks. The acute asthma attacks حكينا عن signs you look for signs of respiratory distress, oxygen requirements. Patients who required previous ICU admission, you should admit them. If you are not certain of the diagnosis that this is simply an asthma attack, or if they fail to respond to your treatment management بالطوارئ, if you're giving them nebulizers and steroids, and still these patients are not responding. Okay. هلا في سؤال عن epiglottitis. Haemophilus influenza is still the most common cause of epiglottitis. إذا بتسألوا إذا شفنا خلال خبرتنا أني epiglottitis very rarely تنشاف nowadays epiglottitis because of the widespread use of the HIB أو اللي هو مسميه Haemophilus influenza vaccine part of the national program بكل العالم حتى مش بس بالأردن. What's the first step of management of acute asthma, chronic asthma? So السؤال كبير. الأكيوت asthma دائما management تبعها stabilize your patient, oxygen, hydration, salbutamol nebulizer. If your patient is known في كثير بهالأيام نلاقي في ناس بالعكس بيسوقوا على salbutamol inhalers أو nebulizers. يعني بطوارئنا بيستعملوا you can usually these patients when they come in بيكونوا مستعملين inhalers تبعهم. In chronic asthmatic patients, they usually try their own inhalers. They don't use the nebulizers unless these patients have moderate to severe attack. Yeah, they have signs of respiratory distress, requiring oxygen, using their accessory muscles. So these patients will stabilization, oxygenation, salbutamol, nebulizer, and then steroids. Within the first hour of these patients presenting with acute asthma, if they are in the moderate to severe attack, you have to give them within the first hour. لو إذا تعطيهم steroids within this first hour, it can help them. لأنه الستيرويدز بيشتغلوا بعد 4 ل 6 ساعات. They don't have an immediate effect للستيرويدز فيهم. بتعطي الستيرويدز, start the steroid management. If these patients in an hour, after an hour still ما في response, بعد ما كان ما أخذ nebulizers, you can use, you can decide the second step على management of these patients. Sweat chloride. Sweat chloride, if you are okay. Sweat chloride for diagnosis of cystic fibrosis. Cystic fibrosis, it's a criteria. It's not the only diagnostic test for diagnosing cystic fibrosis. We have false positive causes of high sweat chloride. Any reading above 60 in chloride measurements in the sweat, يعني لازم يقيس chloride بالsweat. إذا كان more than 60, and then this is in favor of cystic fibrosis. بس لحالها it's not diagnostic لأنه في عندي false positive causes of high sweat chloride testing in these patients. Some of them are endocrine causes, some of them are relating to eczema, so and hypothyroidism, G6PD. So there are many causes of false positive sweat chloride. Diagnostic criteria cystic, sweat chloride is part of that. Diagnosis of laryngomalacia. Laryngomalacia زي ما حكينا it's the most common cause of stridor. Usually, most commonly, these patients typically, زي ما نحكي عن laryngomalacia in neonates, typically they present after the second week of life. So it's not a stridor at birth. It's a stridor at birth. This is not laryngomalacia. Typically, they present after the second week of life, and it tends to improve with age. It's usually inspiratory. Rarely يكون both phases of respiration, inspiratory, expiratory. And this is usually benign. It resolves with age. عادة عمر السنتين most commonly, but some of them ممكن تطلع عمر ال5 سنين. Diagnosis تبعهم usually what we call the endoscopic evaluations, whether من ال ENT جماعة الأنف وأذن الحنجرة أو من جماعة البرونكوسكوبي بالupper airway واللي هم بنسميهم بالendoscopic evaluation of the upper airway. إلها degrees بس usually you should visualize حتى تسمي degrees of the laryngomalacia. ممكن يجي أسئلة على COVID-19. هذا سؤال الانفكشنز أكثر من respiratory لأنه it's infectious disease question. بس ممكن ليش؟ لأنه تلاقيها هالأيام و it has lots of complications وبالadults أكثر من pediatrics. بس ما بنعرف إذا رح يتغير الباترن next winter ويصير في أكثر pediatric age involved. ما بنعرفش. في سؤال chronic nasal discharge أو إذا أنا فهمته صح 1.5 year old long time runny nose no other symptoms what could be. هلا chronic nasal discharge بدنا ننتبه لو في إشي related ل environmental factors وفي إشي if it starts early on in infancy and neonatal period with someone who has chronic nasal discharge. You have to think of what we call the ciliopathy, which is the PCD. Allergy ممكن تعمل runny nose. Infections ممكن تعمل runny nose. فبننتبه لل-environmental factors. If it started the earlier it starts خاصة بالneonatal period early on أو early infancy, it's not allergy. You have to think of other causes. واحد recent onset بس ضل wrong standing discharging nose بدك تنتبه للforeign bodies خاصة بالtoddlers. سنة ونص سنتين بيحطوا كتير foreign bodies بمناخيرهم. So it can be one of the causes to look for, especially إذا كان unilateral. هلا ما في ترتيب acute asthma. use سؤال in acute asthma SABAs then steroids then is if you're talking about usually first line فيهم البرونكودايليترز اللي هم المين ستي اوف تريتمنت to reverse the bronchoconstriction فيهم اللي هو short acting bronchodilators أو اللي هم rescue treatments فيهم. The steroids can be given within the first hour فيهم. فمش ترتيب إنه أنا بعطي ما استجاب عليهم. Moderate to severe attack steroids are indicated within the first hour to be given. Which stridor appears at the first days? Especially stridors related stridors اللي بتكون early on, especially stridors related to upper airway problems, congenital malformations, vocal cord paralysis, laryngeal clifting. It's very important with different degrees تاعونهم. ممكن يكون عند هدول المرضى subglottic congenital subglottic stenosis مهمين فيهم. من ال other things اللي هدول أهم إشي congenital malformations ننتبه لهم لل early onset stridor or within first few days. بعد أسبوعين you think more of benign conditions خاصة إذا ما في other signs that failing to thrive, it's not interfering with their feeding خاصة إذا ما في choking with feeds. Then this is you have to think about that. The other things بالأطفال which is rare بس مش مهم لكم كثير بس إنه usually children later on they could have subglottic hemangiomas اللي هو نفسهم التشوهات malformations تكون بالsubglottic area بتلاقي على skin area and the outside 50% منهم ممكن تلاقي عنده hemangiomas موجودة على الشولدر على النك على upper airway فممكن تكون موجودة تحت. نفس السؤال نعاد 3 مرات أو 4 دكتورة حتى تكتب شيء من الأسئلة. نعطيهم hints مش دائما بشارك فيها بس أحيانا بشارك فإذا بجاوب السؤال. في أسئلة ما جاوبنا عليها. These are the most common broad things. حكينا diagnosis of when to intubate in asthma patients. This is an indication for ICU admissions. Nowadays مع ال role of non-invasive ventilations خف the need for intubation for asthma. وكل الناس بتجرب not to intubate an asthmatic child أو asthmatic person بغض النظر شو هو, trying to use the non-invasive ventilation. Non-invasive ventilations اللي هم مثل CPAP continuous pressure airway أو BiPAP bi-level airway pressure أساس إنه to provide open airways. Patients who are failing. أهم شيء من المتابعة في مرضى الأزمة usually عادة if they fail to respond and they are admitted to ICU still tachypnic and working hard. A normal CO2 in these patients is very worrying. إذا كان ال CO2 هذا ننتبه كمان سواء كان adults أو pediatrics. A normal CO2 in a patient with chronic respiratory condition is not assuring. مو معناته he's maintaining that. It's just telling us that this person has a tendency to have respiratory failure لأنه CO2 بلش يرتفع بصير بدخل عنا other conditions related to acute respiratory failure type 1 type 2 failures حسب إيش underlying تبعته. So this in summary the upper airway lower airway infections هاي اللي بتيجي بالصغار. Other than that chronic diseases ممكن تنسألوا عنهم بس مش دائما, بس أهم إشي later on تميزوا إنه هاي chronic diseases I should think of وإمتى أحول هذا المريض so as not to delay them. حلو الواحد دائما يخلص من الامتحانات وينجح فيهم, بس كمان to be a safe doctor is very important وهاي نصيحة مهمة لأنه العلم بتغير بتطور وبيختلف, وخلال كل دكاترة اللي درسوكم وأعطوكم محاضرات قديش تغير على ال management of different diseases و how we look at different things. cystic fibrosis كان من الأشياء اللي ناس تخاف بس تسمع اسمها هلأ سواء كان بعمان أو ببريطانيا هون it's one of the treatable diseases وعم بتشوفهم ما بتقدر تميز إنه هدول they are مرضى cystic fibrosis. كل العلم بتغير. good luck وإن شاء الله دائما نقدر نساعد أي حدا ويعطيكم العافية, وأي أسئلة تانية سواء هلأ أو بعدين ذكرتوا أنا جاهزة وليهمكم ويعطيكم العافية وشكرا.